Hey, good afternoon, everybody, and welcome to the first of our two webinars of our Hit the Road Hep C and Don't You Come Back No More webinar series hosted by the Physician Learning Program and the Office of Lifelong Learning in collaboration with the Edmonton North Primary Care Network. My name is Panita Tandon. I'm a hepatologist and medical director at the Office of Lifelong Learning and the Physician Learning Program. The PLP creates actionable clinical information by engaging with physicians, teams, partners, and patients to co-create sustainable solutions to advance practice. The PLP is dedicated to moving evidence into practice, fostering a culture and environment where everyone works together to tackle our most pressing problems, advance patient care, and create a world-class sustainable health system, which includes important topics such as the one that you will hear about today. Next slide, please. For our land acknowledgement, we acknowledge that we are on traditional territories across Canada of the many First Nations, Métis, and Inuit whose footsteps have marked these lands for centuries. And just a little bit of housekeeping information before we start. If you could please use the chat feature if you have a question about technical difficulties or L3 programs and services. If you have a question for the speakers, please use the Q&A feature of the webinar. Please review what's already been asked, and if you can upvote those questions you'd like answered. And we will do our best, but we can't guarantee that, that Dr. Rose will be able to respond to all of your questions. There will be a recording of the webinar and Pearls of Practice that's sent by email to all those who have registered after the second session on March 6th. You can claim CME credits and complete a personal development activity using the My L3 Plan tool. And for more information, you can use the QR code. And just a note that this activity has not been formally reviewed by the CFPC or the Royal College, but it is eligible for non-certified credit. Main Pro Plus participants may also earn additional certified credits by completing a linking learning to practice exercise. And we are very pleased to have Dr. Matt Rose presenting to us today. Dr. Matt Rose is a family doctor, a clinical professor in the Department of Family Medicine at the University of Alberta, and the Associate Medical Director at Radius Community Health and Healing, formerly known as the Boyle Macaulay Health Centre, which serves Edmonton's inner city. His practice interests include primary care for people with substance use and addictions, HIV, hepatitis C, and ethical and social issues involving marginalized populations. Thanks so much, Dr. Rose, for joining us, and everyone, welcome to our webinar.
Thanks for the introduction, Panita, and welcome everybody. Happy to be presenting on this. One of the reasons I'm actually here today is I'd originally reached out to our PCN because I was thinking that I'd heard that there was a goal. I'm not going to tell you exactly when that goal is because that's going to be one of our questions. But there was a goal of eliminating hepatitis C, ideally worldwide. The World Health Organization had set this goal, which kind of took me aback a bit and got me thinking about my own practice. And we see lots of people with Hep C, and we're pretty aggressive in treating people. But I think there are lots of perhaps other people out there in broader and different populations that might very well benefit from being screened for and then treated for hepatitis C. And so that through a bit of a tortuous path, we ended up here today. So I'm hopeful that you will find this, that there will be some new information for you, and it will also help you feel a little more comfortable about screening for and providing care to people with hepatitis C or who might have hepatitis C in your own clinics. I'm going to share my screen now with the slide presentation. Just to give you a bit of a heads up, there is, as we go through, there are several kind of polls where I ask multiple choice questions, and then we'll pause for a few seconds for people to make their answers. It's not, it is anonymous. So if you're like me and you don't like to openly display your ignorance, you can do so covertly. some of the questions will be obvious, I hope. Some of them will be a bit surprising to you. So without any further yammering on my part, let's move ahead. So the disclosures, I do talk to pharmaceutical company representatives, but I don't take any money or other incentives from them. Our clinic, Radius Health, does take grant funding for some of our patient support programs related to social stuff, not related to drug use specifically. And it's important to recognize that I see the world certainly of primary care through a bit of a specialized lens in working with the marginalized population that I do. So much of what I say how I think about things is certainly first and foremost about our population here. And so sometimes it does not apply as broadly or as directly to other populations, including the populations you may be seeing in your clinics. So here are our goals for part one of the two parts. And the first part is to identify the populations that should be screened based on the risk factors, describe the risks and recommendations about screening in primary care, and interpret the screening results and inform patients appropriately. Oops, here we go. So we're going to start off with a bit of a question. Here's our first poll. And which of the following lines or most accurately describes the relative risk of having HCV based on area of origin? So if you were born in North America, your risk would be less than if you were born in South America, less than if you were born in Africa and Southeast Asia. So you can choose 1, 2, or 3. We'll give it 10, 15 seconds. And hopefully the less than and the equal signs make sense to people. And I've tried to also increase the. Okay. Do we have any results yet?
I think we might just need to give it a couple seconds, Matt. I see them now.
Excellent. Okay, perfect. So we've got about 2/3 people think line 1 most accurately reflects. 1/3 the second line, and nobody chose the last line. Okay, so let's have a look here. Well, in fact, it is the last line. If you are, and I'm just going to go back so we can see those. Europe and the Eastern Mediterranean. Now, Europe's a bit tricky because obviously it's including what used to be Soviet bloc countries. So Eastern Europe, as well as countries like Ireland and Portugal. But in fact, your risk of the rates of hepatitis C in North America and South America are about the same. The best incident rate. And you'll see in Europe, you're looking at 61, 62% here. There are wide uncertainty margins and so on. I think the takeaway message here is that people who come from, depending on where you come from in the world, your risk of having hepatitis C varies significantly. And that is one of the factors that should alert us to whether or not we need to be screening or should be offering screening for people, especially people who are immigrants to Canada or children of immigrants. So In Alberta, people who come from higher prevalence countries and women who are pregnant are routinely screened for hepatitis C. True or false? And our poll should come up here. There we are. Okay. So let's move that along. So we're about even. This is so 50, about 50-50. Half of you are correct. That's okay. In fact, pregnancy, the routine screening of pregnant women in Alberta does include HCV screening now. Women are able to opt out, just they are able to opt out of HIV screening and so on. But it does not routinely, we nationally and provincially, there is no requirement or a specific guideline that recommends screening for all immigrants. But there is some a really good evidence-based screening recommendations, not just for HCV, but for many infectious diseases ranging from parasitic through viral. The website that appears here on the slide will also be available offline through the Office of Lifelong Learning. And this is we have to pass on our thanks to Molly Whalen Brown, who is the medical director of the New Canadians Health Centre. She gave us a lot of really great insights into some of the particular concerns around HCV and other issues in New Canadians or immigrants. One of the things I would add, in higher prevalence populations, it is worth considering that it's not just people who are immigrating from those countries, but the children of those people with a higher prevalence there is a risk of vertical transmission of hepatitis C, which is generally estimated at about 5%. Those are maybe older figures. But that's still a consideration. And I think now so if you're seeing people who are children, second, potentially even third generation Canadians who have never been screened or whose parents have never been screened, that is also something worth considering. Okay, so as I mentioned earlier, the World Health Organization has set a goal for the elimination of viral hepatitis, not just Hep C, but Hep B as well, as endemic infections, so not complete eradication, but as kind of enough, an endemic infection is enough to perpetuate the existence of the infection. If you get below endemic levels, ideally in populations, it will die a natural death because the rate of transmission is not high enough to sustain it. So what is that date that the World Health Organization would like to see hepatitis C eliminated by? 2030, 2040, or 2050? 6 years, 16 years, or 26 years from now? All right. So let's say, so it's evenly split between 2030 and 2040, and a few people are what might seem more realistic and hoping for 2050. Excellent. Good. Thank you for your responses. In fact, it's 2030. This was the number that surprised me when I heard about it, and that got me thinking about stepping up our game to get rid of hepatitis C. As I thought more about it, and I think this is one of this is why this interests me and motivates me so much. It is not often, certainly in the last several decades, where we as physicians or providers of any type can be involved in the elimination of a disease, or essentially the elimination of a disease in our practice lifetime. And hepatitis C, which was when I went to medical school a little over 25 years ago, was it had been recently characterized, and the fellow who headed the lab that really kind of identified hepatitis C is still, as you're well aware, working at the U of A toward trying to find a vaccination for hepatitis C. So a lot has changed and certainly in my practice lifetime, and I find that astonishing. And to think that by the time I retire, which is planned for 2029-ish, hepatitis C may be eliminated. The other thing that I found not absolutely astonishing, but so impressive, is the World Health Organization is giving this giant shout out to Egypt. What Egypt has done in the space of about 10 years, maybe 15 years, is they just offered universal screening and universal no-cost treatment. And so 93% of those who were diagnosed, so they've diagnosed 87%, they estimate, of the people living with Hep C, and 93% of those had curative treatment. So they're exceeding the WHO targets of diagnosing at least 80% of people living with Hep C. And it's just, and it's not like Egypt is a third world country at all. It's a developed nation, but it does certainly have its public health struggles, as every country does. But that shows what happens when the governments and the healthcare system, and let's basically all systems, come together to focus on an important, realistically achievable goal in health. Now, so yay for Egypt. What about Canada? So which of the 3 provinces lag behind on being target to reach the 2030 elimination goal? I can tell you all but 3 of the provinces are on target to reach that 80% diagnosed, 70% treated. So is it Alberta, Saskatchewan, Manitoba, Ontario, Quebec, or New Brunswick, Nova Scotia, Newfoundland, and Labrador? Which 3 provinces lag behind? Okay. The Alberta advantage. Almost half people think that's right. About a third of considering our maritime provinces are too busy fishing to be paying attention to hepatitis C, and safely in the middle, considering themselves superior to everyone else, is Ontario, Quebec, and Manitoba's tagging along behind them. Well, in fact, yeah, not so much. Everybody except Manitoba, Ontario, and Quebec are on target, including Alberta. Look at Saskatchewan. I mean, and PEI has already reached their target. Now, a lot has to do with the prevalence, any number of social factors that play into this. This was from 2022, and things change pretty rapidly in the Hep C landscape these days. So that's a bit illuminating. So I was rather surprised and pleased to see that Alberta is not lagging behind in providing one aspect of care to our people. So So let's talk about who should be screened and who should not. Which population should be advised not to have initial HCV screening? So no, if somebody says, I need to be screened for hepatitis C, you're going to say, nope, you don't need an antibody screening for hepatitis C. People who, whoops, now I've given away the answer. People who inject drugs, people from countries where the prevalence of HCV is high, people currently living in correctional or have been living in correctional facilities, Indigenous people, including First Nations and Métis, or gays, hang on, anyone born before 1950, people previously treated for HCV, and anyone who asks for it. So I'm sorry, you can all read just as probably better than I can speak. So, all right. Yes, people previously treated. That is exactly right. Essentially, once you've had when you are infected with hepatitis C, your body develops antibodies. About a quarter of people will spontaneously clear hepatitis C on their own. Because there are many subtypes called genotypes of hepatitis C, or different flavors of the hepatitis C ice cream, immunity to one flavor does not guarantee immunity to others. But the hepatitis C antibody means you've been infected by one of the genotypes. Retesting, and that antibody will basically remain in your system and detectable on the antibody screening test for the rest of your life. So there's no point in rescreening. All it does is it's repeating a test that will always be positive. I will, after a slide or two, explain what you would do with people who have previously been treated for hepatitis C should the question of HCV screening come up. Okay, so and as I say, anybody who wants screening, that's the bottom line. Whether they're at risk or not, if there's no identifiable risk, someone asks for HCV screening, you can't find any antibody on file, they don't know that they've ever been screened before, go ahead and screen. Even if they have been screened before, the screening test is inexpensive, and it's better to do it twice than not do it at all when it might be necessary. So the next question is, can't see my slide here. Well, sorry, I just need to move stuff. Higher risk population. Okay, this is not a question, it's just, so obviously people who inject or use drugs, including non-injected drugs such as snorted cocaine or inhaled opioids or methamphetamine, including fentanyl and methamphetamine are currently widely smoked, especially in younger populations, much more so than injected. People from countries where prevalence of HCV is high, people currently or previously living in correctional facilities, Indigenous peoples are at much higher risk of acquiring hepatitis C just because the prevalence is higher in those communities. And gay, bisexual, or other men who have sex with men, because the type of sexual practice exposes individuals to a higher risk of blood-to-blood contact, which is the way hepatitis C is spread. Hepatitis C theoretically can be spread through other routes, including sexual transmission, but it is very rare. It's much less transmissible than HIV, for example, and certainly less transmissible than STIs and so on. The use of barrier methods for any sexual practices, but particularly for higher risk sexual practices, is recommended and is generally the best way of preventing HCV, HIV, and any other STI transmission. So when it comes to hepatitis screening, what do you do? And the first bit, I think, is the most important. Someone in the room, either you or the patient or one of their family or friends or someone interested in their well-being, needs to have the discussion. I mean, you need to think about it. And because HCV prevalence in the general population is not high, it's from less than 5% in the Canadian population overall, it's not high on our list of things to be looking for, like diabetes or substance use disorders, just putting a little plug there, hypertension, and all the other sorts of things that cause a lot of morbidity and mortality in our populations. Why then am I going on about screening for hepatitis C? For a couple of reasons. Number one, it can be eliminated so we don't have to think about screening for it anymore. Number two, it is an expense. It is a significant expense to the healthcare system. It is the principal, well, viral hepatitis, but hepatitis C being a big part of that, is the main cause of liver cancer. And it also contributes significantly to cirrhosis. And these conditions are very expensive for the healthcare system to treat and cause significant morbidity and mortality. So it is something that we can screen for, detect, and actually treat really easily, not cheaply, but all things considered, relatively cheaply and effectively. So the first point is have the discussion. Sometimes, and I think this is where we as primary providers or specialists sometimes have a bit of discomfort, perhaps, in having that discussion, because there is a hepatitis C is like from IV drug users, or there is a perhaps a bit of shame associated with having it in many situations. And I think to be comfortable with having the discussion. So here are the generally the groups that are higher risk. Do you fall into any of these categories? Is not the easiest discussion to have, particularly when it's people who were born in the 50s, partied hard in the 70s, and may have done some injecting once or twice, and acquired hepatitis C at that point, and then that was part of their misspent use, and they're entirely just a normal, boring people these days, or looking at retirement or retired and have never been screened. One of the so what actually is really helpful in these situations is to have posters in your waiting room or in your exam rooms that kind of spell this stuff out, as well as invite any of your patients to ask for screening if they would like to be. So, and as a result of this presentation or something like that, you might say, well, as far as I'm aware, I don't see that you have any particular risks for hepatitis C, but since we're doing some blood work anyway, and you say you've never been screened, would you like to do the screening? And the reason I offer it is if you do, in fact, come back with hepatitis C, which would be bad, we can cure you, which is good. So you order the test. Once the results come back, positive or negative, you review the results with your patient. You counsel risk avoidance as appropriate. So how to keep from getting hepatitis C in the future, or pass it on to others. And then you refer for treatment if you don't want to treat the hepatitis C yourself. So I hope Dr. Tandon is not paying too close attention to my little slide because I've taken liberties with what the lab will report. But I just wanted to share the basic process of what happens in Alberta now with screening for hepatitis C. The initial screen is an anti-hepatitis C antibody. If it's negative, that means the person has never been exposed to hepatitis C. And if there are ongoing risk factors, including ongoing IV drug use, unprotected sex at particularly high risk, that sort of thing, then you might consider rescreening at regular or as needed intervals. If it screens anti-HCV antibody positive, the lab checks to see if there is a previous positive on file. And essentially it says, this is a previous positive, please refer to, and they will give you the date of the initial positive screen. And they'll also chide you about not using Hep C screening, antibody screening, as a way of monitoring the Hep C condition if the person actually has it. If it's a first positive, they do what's called reflex testing, where it will automatically go to a specialized test to look for the presence of hepatitis C itself, the RNA. As I mentioned, 25% of people will clear hepatitis C spontaneously. Some people may have, in fact, been treated and have forgotten. That's about 5% of my population. But most people know if they've had hepatitis C and have been treated. So that screening is for the HCV RNA. If it's negative, you can tell your patient, no, you do not have hepatitis C. It's possible to get hepatitis C again in the future, but you should not get screened again for hepatitis C. If someone says, oh, we are screening you for hepatitis C, or we did a test for hepatitis C and you have hepatitis C, you need to be clear that, no, you don't have hepatitis C. You had the screening test, you had hepatitis C, you don't have it now. The RNA was negative, or the backup test or the confirmatory test was negative. And that's sometimes that's a message that people don't often get when they have screened positive, sometimes because we as the providers don't pass that on clearly enough, or we don't understand it ourselves. If it is positive, then you get it quantified with a viral load. So how many copies per mil? And I've seen, people have with 200-300 copies per mil, which is actually quite low, to tens of millions of copies per load, tens of millions of copies per mil. That does not necessarily indicate how bad hepatitis C is, or damage to liver, or anything like that, or what will happen with the hepatitis C. It just means that hepatitis C is present, and the person should then be referred on the person should then be treated. There is indeterminate, and that one's a little trickier. Usually the lab result gives good advice, which you should follow, about how to proceed. The lab tests really are very accurate, and I've seen an occasional indeterminate. You test again in the window that they recommend. These windows get smaller and smaller as the tests get better and better, but it's typically within 3 months. And particularly if and then if it's again indeterminate, you can always call the virologist on call, or your favorite hepatologist, and they or ID specialist, and they can help you navigate the next steps. Okay, so if you've been paying any attention, which is not easy with me going on and on, so the result comes back antibody positive, RNA viral load of 11,234 copies per mil. So your advice to your patient should be, One, be on medication to cure the hepatitis C. You don't really have much hepatitis C, so there's no need to have treatment soon. And you can't pass on hepatitis C to your family members. What should your advice be to your patient? And you have to choose one. All right. Okay. Yes. Thank you. Thank you all. Yes, you should be on medication to cure your hepatitis C. Nothing could be simpler. One of the things that I tried to throw in there to maybe throw you off a little bit was you can't pass on hepatitis C to your family members. You absolutely can if you and your family members are sharing injection drug use equipment, or, you know, cutting yourselves open and pressing your wounds together and that sort of thing, as well as unintended sharing toothbrushes, and there's blood on a toothbrush and it gets, you know, it's fresh blood and it gets, somebody else uses it. And you know, these very rare, but still theoretically possible. So, you're very unlikely. You can't pass on hepatitis C to family members except through blood-to-blood contact, which basically excludes most of the normal familial interactions. So, what is not the take-home message? Anyone who wants HCV screening should be screened. Anyone who comes from a population at increased risk should be screened. Anyone who is RNA detectable should be offered treatment. And anyone who is anti-HCV antibody positive but RNA negative doesn't need follow-up. Which of these statements is not correct? All right. Okay, 2/3 of you chose the final one. Doesn't need follow. Okay. Yes, in fact, and this is the trickiest, I think, of the questions. I'm certainly happy to go into it in more detail. If ongoing risks are present, fairly significant risks such as ongoing IV drug use, it may in fact be advisable to request repeat RNA screening in where there's a previous positive antibody and a previous negative RNA, but the lab will require an explanation as to why there is rescreening. So ongoing risks present or recent exposure to active hepatitis, that sort of thing. If there are no risks identified, then ongoing screening is not recommended. And often in the case where ongoing screening with a antibody positive RNA, previously RNA negative, where you might be asking for repeat RNA, often that would be it would be ID or hepatology that would be dealing with those folks typically. Okay, and that is the end of my slides. I'm going to stop sharing now. And am happy to entertain questions. And we are very lucky in that with having Dr. Tandon here, who can ask some of the higher level questions that I'm not so familiar with.
Thanks, Dr. Rose, for this excellent presentation, updating us on the topic of screening for hepatitis C. Before we go to the Q&A, I just wanted to go over a few things here. So my name is Nandini Desai, and I'm the clinical liaison with the Physician Learning Program. I would like all the people in the audience to just think about and do some reflection and see how can we incorporate this new information into our own practices. And studies have shown that when you have good ideas for change, you're more likely to put them into action if you write them down. And the Office of Lifelong Learning and the Physician Learning Program Office has prepared a platform to help you make a personal development plan which will also earn you credits. This platform is called My Lifelong Learning Plan. And the link to help you access this platform will be placed in the chat box by Natasha. Thank you, Natasha. So what is My Lifelong Learning Plan? It's a free online tool that can be used to meet and support the 3 activities or action plans that are required by the CPSA's Physician Practice Improvement Program and earn CME credits by completing the following 3 cycles. So you can do a practice-driven quality improvement activity using objective data, and you can earn 12 credits by doing so. Your personal development plan cycle gives you 6 credits, and your standard of practice quality improvement activity can earn you 6 more credits. So let's go over an example of a goal that you may wish to consider for a personal development cycle. For example, you may wish to increase the number of patients you screen for hepatitis C in your clinic. Here are some things to consider. Do you know how many patients in your practice have the risk factors that Dr. Rose mentioned? How will you identify them? Do you have some supports or resources within your clinic that can help you? Many primary care networks have improvement facilitators or quality improvement teams. Do you have one? How will you measure if you have achieved the goal that you set out to do, which was to increase the number of patients you screen for hepatitis C? The My Lifelong Learning platform allows you to keep a track and document all these questions and answers and submit your work for 6 credits. Another way to get credits is by completing a linking learning to practice cycle. This is a self-administered, semi-structured reflection exercise which provides CFPC members with an opportunity to earn 5 certified main pro credits as self-learning activities. And the forms are available on the CFPC main pro portal, and Natasha will place it in the chat box. And now I think we're ready for question and answer, so I'll hand it back to you, Dr. Tandon, to take over. Thank you for your attention.
Sounds great. Thank you, Nandini, and thank you, Matt, for such a practical talk. I really loved how you used the questions there throughout. That's really engaging. Keeps everyone awake. So fantastic. Okay, I'm just checking the Q&A box. We've got a question from Robin, who is asking, with marginalized populations, especially getting lab work done can be challenging. Do you have any suggestions on how to increase the likelihood of completing Hep C screening? Great question, Robin.
An excellent question. Yeah, you can order all sorts of tests, but if they're not actually done, this is interesting because there are point of care tests, but they actually may where you can do a little blood poke and you can actually diagnose Hep C antibody, but that's not going to tell you whether they actually have active hepatitis C. The best thing to do is have a lab in your clinic, which we are fortunate enough to do. Now, chances are you're not going to build that from the ground up. I think unless you're willing to draw the blood yourself, or you have someone within your clinic who is, has those phlebotomy skills, maybe the best way of convincing people that it's worthwhile actually getting the testing done is to say, if you have hepatitis C, then we can have you cured in under 6 months. If you have hepatitis C and you don't get tested, you will still have hepatitis C, and it will be causing more damage to your liver, and it may end up with all these things. So it seems to me the best thing to do, find out what the situation is right now. Because if it's bad news and you have hepatitis C, the good news is we can cure you. If it's good news and you don't have hepatitis C, then you've, avoided the testing for nothing. But I don't know quite how helpful that might be. It's just like getting A1Cs and doing all the things that we all should be doing to look after our health, and tend to like to procrastinate or avoid if we're afraid of the answers. But I think saying, if it's positive, if you have hepatitis C, you won't have hepatitis C in 6 months. That can helps people look beyond the worry about the diagnosis. Any other thoughts? I mean, Dr. Tandon, you will usually see people after they've had the diagnosis and so on, but your thoughts on that?
Yeah, no, it's part of our routine screening. I was thinking we actually just pretty much when they're seeing us, they would have all of those tests done prior to coming in, just for efficiency. But
Yep.
I don't know, Nandini, can people in the audience talk as well and unmute, or
Yeah, they should be able to unmute.
if anyone has other thoughts? I'm sure there's some other very
Yeah,
smart individuals on. In the meantime, we can go to the next question, which is apologies if I say your name wrong, Tetsuya. An organ donor with Hep C antibody positivity and HCV RNA negative. Is this donor suitable for transplant?
Why don't I ask Dr. Tandon question? I think I know, but let's ask someone who really knows.
Yeah, I mean, so as you mentioned, they're HCV RNA negative, which means their hepatitis C has cleared. And we're even transplanting Hep C positive organs now, knowing that we're quite confident that we can clear hepatitis C. So it's really quite incredible. I would agree with you, Matt, to see that shift even over our practicing careers in this condition.
Sorry, I just wanted to add, if anyone from the audience has comments or questions, please put them in the Q&A, as they won't be able to speak on the webinar, but they can definitely comment.
Okay, they won't be able to speak. Thank you so much. And there is in the chat from Tara, a group of our Edmonton North PCN members who work with a similar population to Radius had one of their staff trained in phlebotomy so they could do blood draws within the clinic to get the sample while the patient was present. Yeah, I think that's exactly what you were speaking about, Matt.
Yep.
Nothing like point of care for everything.
Yep. Nothing like having lab on site. It's makes it much easier to look after people and help them be healthier.
And I very much liked your suggestion of the poster as we're waiting for. I'd encourage you guys to ask any other questions if you have them. But I really did like the practical poster suggestion there about how to even, bring up the conversation.
Yeah, and I think it's Katie, CATIE, the Canadian something of something and something. There are any number of resources, including posters that are sort of you're encouraged to download and print off and post and stuff. One of the things, the difference, I'll just mention that there's a difference between the American and Canadian guidelines for screening recommendations for Hep C. The American guidelines basically says anyone over the age of 18. Certainly there people who are, it's interesting if you look at the sort of decade cohorts of relative prevalence of Hep C, because people who are born in 1940, 1950 have a higher prevalence than those born in 1960. And it's they're sort of varies, which represents the sociological phenomena that were occurring at the time. But I think it's a cheap test. It's a couple of bucks to do the antibody test, and to eliminate, to basically get a disease out of circulation, both on an individual basis and on a societal and worldwide basis is definitely, I think it could be offered as routine screening? Excellent question. Yes, Dr. Tandon, I will.
No, you take it, Matt. You go for it. It's your webinar.
Sure. Okay, treatment with oh good. Okay, so you know what I'm going to do? I'm going to answer this question next week, because next week is all about referral for treatment and some of the considerations around that. In fact, on the slides that I'm making up for next week, there is already one about pregnancy. So I'm going to defer that to next week, and you're going to have to tune in next week to get the answer. How's that for a cliffhanger?
That's amazing. Yeah, I love it. Would we expect LFTs from an anonymous attendee? Would we expect LFTs, if abnormal, to revert to normal with successful treatment? And what role do serial liver function tests or liver enzymes play in management?
Excellent question. If hepatitis C is the only hepatotopic issue, that, the only thing affecting the liver, and they have an elevated ALT, which typically for hepatitis C, it would be really just the ALT that's elevated. And often in chronic hepatitis C, it's not that high, so it would be, and often in the normal range. So normal to, 1 or 200, whatever the units are. If hepatitis C is the only thing affecting their liver, then yes, they would normalize. But I've seen people with viral loads in the millions with a normal ALT, which is pretty, I don't see it often, but it does happen. The other thing to bear in mind, though, is there are lots of things that can cause people's liver enzymes to rise: alcohol, genetics, non-alcoholic fatty liver disease, other viral infections, all sorts of things. So, and essentially, once someone has been treated for hepatitis C and their viral load is cleared, there is no further screening for the hepatitis C. There's no further screening required. But if people already have damage to their liver as a result of hepatitis C, then that's a different kettle of fish, and normally you'd have a hepatologist involved at that point if there's fairly significant cirrhosis or certainly any indication of hepatocarcinoma or anything like that. But if, and it's not unreasonable, and actually in some cases a good idea, particularly if liver enzymes, the ALT and other liver enzymes don't normalize, you might very well want to do an ultrasound, including FibroScan, just to get a better idea of what might be going on with an individual's liver. Is it absolutely necessary? No. I will touch a little bit on some of those considerations of aftercare in next week. So next week is all about treatment and aftercare. So I'll be able to answer that in greater detail. Did I leave out anything significant, Panita?
No, I think just the key is to stage. I would agree. Like even if they're Hep C positive, for sure we would want to get some staging of their disease, generally by FibroScan if we're seeing them in the clinics, but you can use Fib4, I guess, as an estimation as well. And there's that elevated liver enzyme pathway, which is available online. If you just Google it, AHS elevated liver enzymes pathway or fatty liver pathway. So that'll also point you to the Fib4. But we can't miss those who have cirrhosis for sure, because that's a whole nother pathway that they need to follow. Excellent. See if there's any more questions. Looks like we're good. So I guess we'll maybe, if we're okay with that, we can leave a little bit early so that we can give you some time to, or end a bit early so we can give you some time to fill out the feedback forms. Is that all right, Nandini and team?
Yes, so just to let everybody know to fill out the feedback form, and there is a opportunity to win $10 Starbucks gift card as a reward if you want to go for that. And also, Natasha, the next slide, if we can just talk about the next week's, just make sure for people who have not yet registered but are interested in learning more about managing and referral regarding this Hep C, so the second of the last webinar, then please go ahead and register using that code, the QR code or the link. And hope to see you all next week. Thank you, Bonita.
Yes, thank you, everybody. And thank you, Matt, for
and thanks, Dr. Rose, so much for a super job, both of you, and for doing a great job.
Absolutely my pleasure. And I just want to point out that I ended on time for once in my life. So I'm keeping my fingers crossed. I will be well behaved next week. And I look forward to seeing you all then.
Okay, and thanks for the evaluations, everybody. They really mean a lot for our end. So take care.